I work at the Luton and Dunstable Hospital, and I just want to give you a quick overview of what it is that we're talking about here. So this is the patient management system. You can see that you can put in the patient's name, hospital number, disease. You're documenting, this is the clinic contact page, so you're documenting who's seeing the patient, what type of visit it is. You're putting in the current weight, the height ported over from the last time you were on the system. It calculates out the BMI for you, and then there's a quick assessment as to how that patient's been over the course of the year. If they've got Crohn's disease, it will then take you to a Harvey-Bradshaw score. If they've got ulcerative colitis, it will take you to a UCD-AI score. And there are assessments for severity and extent on here. It's simple. You may not know how to do these, but it's nice, simple drop-down menus, and it guides you through. For the pediatricians in the audience, there are growth charts, so you can easily document both height and weight. The surgery tab used to contain every known possible surgical procedure, but this has been simplified with just those most salient to gastroenterology. The drug history is always the bane of any database, and this has been simplified as well by separating the medicines out into 7 key groups. And here we've got the immunomodulators opened up. You just click on one of these and the whole line gets downloaded. And azathioprine, because it's weight-based, you have to go in and put that one in the dose in yourself. This is the investigation and management page. At the top, you can see that, that up here, you can highlight the blood tests you're going to be performing, the stool tests, and then these sets of boxes here, these are work lists. We use this quite a lot. We use this for our colonoscopic surveillance. We put a colonoscopy here. We want to be reminded in 5 years' time. They give us a little reminder 3 months beforehand that we've got to start trying to facilitate these in our colon lists. You've then got a problem list. Now, anyone with an iPhone will be familiar with this. You put your problems down here, what you're going to do about it over here. And then these get ported over onto your disease summary sheet and also onto your letters, unless you've clicked it and then it's removed. There's an outcome drop-down menu. This is about the only free text box here. And then just by putting a little tick here, it will instantly generate a letter. Now, this can be adjusted per hospital with your own letter heading on, and whatever information you want on that letter. So this is very easy to manipulate. The disease summary sheet pulls together all that information so that just with a hospital number or their name, you get a quick reflection of what's going on with that patient. And the bit that I haven't put on down here is the drug history, what they're on, and also what they were on, but you had to stop because of side effects. So this is also a snapshot view, a local data report gives you a quick eyes view of your patient cohort. So last BSG, I pointed out that when I first got going with this system, I was mortified because it was taking me about 14 minutes in a clinic to upload this information. And I really didn't think that this was going to go anywhere. But it doesn't take long, and by about 12 patients, I was starting to get through this in 5 minutes. And if you don't believe, 4 minutes, sorry, and if you don't believe that, there are videos on the BSG site, and it can be done fairly comfortably. I'm now seeing these patients come back again, and I can tell you it's a lot quicker the second time round. It takes me about 2 minutes. I don't do it during the consultation now, I just do it at the end. And if they've had a particularly complex surgical history, I use that time to then go back and upload anything I didn't do the first time around. There's a telephone clinic sheet for mainly for our nurses, and it documents the amount of time it took on the telephone, but also the amount of time it takes to actually sort that problem out. So something that's been missing for a while. Also, whether or not you've saved a clinic, and I'll come on to that later. So some of the recent improvements, there's generic information sheets on there about the consenting process, about the echo immunity and vaccination protocol. I've talked about the simplification of the surgical tab. There's a visual timeline here, so you can actually see across the patient's disease, how many times they needed steroids, when they needed to have surgery, and that can be very useful just to see a quick visual overview. There's a virtual clinic tab that's now gone in as well. So why did we get involved? Well, at the L&D, Luton Dunstable, we have quite a large cohort of inflammatory bowel disease patients. And I was running another project called IBD SHAMP, which stands for Supported Self-Help and Management Program. It's a way and means of monitoring patients out in the community, our more stable patients. So I needed a really good functional database, and I was lucky enough to get invited by the BSG to get involved with developing the registry. It makes auditing and research much simpler, and we were looking to get some money from our commissioners to fund additional IBD nurses. And it's our trust aim that by the end of 2015 that we're aiming to go paper-free. So I started with a simple Excel spreadsheet, 2,850 names. I had half of those patients on the Rotherham database. Now, Sims very kindly built a little package for us to port over the most salient features of the Rotherham, to literally lift it and put it straight into the registry for me. So that was half of my patients done almost overnight. So that left me the other half of the patients to get through. And just to show you how quickly this can be done, this is just myself and two IBD nurses, just through clinic contacts and telephone contacts. Within 3 months, we could upload 300 patients. So the training varies in time. You can get through the basics in 30, 60 minutes. Obviously, if you want to know how to use all the little buttons and all the modalities, you just need to sit down and get using it. So I started this off just myself and two IBD nurses. Subsequently, one of the other consultants has come on board. Our SPRs were obviously interested for training purposes. Our secretaries have asked to get access. And just recently, we've now had our lower GI surgeons and also the pediatricians ask for access to the information. So it's now trust-wide. I can get access to this in any computer in the hospital, provided I have my access codes. It's also live with PAS details. So benefits, instant benefits, access to information. There's the summary page. There's the dashboard, so at any one point in time, I can tell exactly how many patients I'm looking after, how many have got lymphocytic colitis. It's certainly helped audit and research. The instantly generated letters, something I thought was a little bit of a gimmick. I've mentioned this before, but I'm completely sold on this now. It has an incredibly positive effect on the patients, and also our GPs really like this as well. And finances I'll come on to in just a minute and how we've used it. So we also use the checklist quite a lot, both the immunity protocol and also pre-biologics and pre-infusion checks. Work lists, we've got the colonoscopic surveillance I've talked about. We use this for our multidisciplinary meetings now, who we're going to talk about, what we're going to talk about, and in the meeting itself, we can actually upload directly onto the registry the outcome from that meeting. We're also using this to set up reminders as to who needs further azathioprine monitoring. So that's another way we're using it. I'm not going to talk about the standards or global rating score. We haven't redone this yet, but I'm fairly certain our patient satisfaction audit will have gone up, our results. So I just wanted to talk about finances. We weren't doing this before, so we brokered a deal with our CCG to be paid the grand sum of £23 if we could save an outpatient appointment. Now, our IBD line, last year we had 2,205 telephone calls come through that line, and we were able to save 250 outpatient appointments. Now, that saved some money, not masses, but some. We also run telephone clinics, and we deal with about 50 patients through the telephone clinics every month. And now you start to see these sums start to build. And this has gone part way to funding our additional 2 IBD nurses. So I just wanted to touch on a sideline project. We call this IBD SHAMP, Supported Self-Help and Management Program. We set up personalized websites for all of our patients to really help and support them manage their condition better themselves out in the community. And we were really lucky. The guys that set this up for us, Patients Knows Best, SIMS allowed us to integrate into the system. So all that information that we put on now as a single point of data entry gets lifted and then dropped into these websites. There's a symptomatic assessment score and a scoring in color-coordinated fashion, so you can see the way that symptoms change over time and maybe improvements with medication. If anyone scores badly, we get an alert in the hospital so we can contact them and optimize their management. Now, none of this would have been possible without the help of the Inflammatory Bowel Disease Registry, so I'm very grateful for that. And off the back of this, we were lucky enough to win the SAGE Innovation Award last night. So there's a cost to putting in a system like this, but at the same time, there is a saving, and it saves our CCG about £130,000 a year. So we're not the only users. There are other active users at the moment, St. George's, Norfolk, UCH, Princess Alexandra, and Barts. And there are other people that are either on board or they're being set up as we speak. Birmingham, Royal Berkshire, Derby, Worthington, Nottingham, St. Helens, Barnsley, and soon, I believe, East Surrey. So I've had a little bit of feedback from a couple of these sites. Birmingham, unfortunately, the actual costs were a little bit more. They're a little bit higher because their IT department made them buy a whole new server to host this. Seems a little bit harsh, but there you go. But so far, so good. St. George's, they're just waiting an update on their Infoflex before they can use the new upgraded registry. Newham hit a bit of a stumbling block here with IT engagement. Royal Berkshire seem to have sailed through this, funding and setting up, no problem. They've even managed to get a part-time admin person to upload their data for them. I'm very jealous about that. St. Helens and Knowsley had problems convincing their trust about the funding, but once they were up and running, they then hit the IT blockade. And then University College, again, usual IT issues. I think they're up and running now, helped by the fact that they had Infoflex on board. Stuart tells me he's the main data inputter. I'm sure his IBD nurses would disagree with that. He's finding it a little bit difficult getting in the clinical setting, but I'm sure once he's over 10, he'll be flying. So clearly, common theme here, IT departments. They're a law unto themselves. And so the BSG and also the head of NHS England are putting together letters that are going to go out to the chief executives of all the hospitals to try and lend a little bit of, put a bit of pressure on IT departments to make this a priority. Most common question I get asked is, does it help with azathioprine monitoring? I set up work lists and reminders, but there is a package that is in development. I'm not sure I'm allowed to say much more than that, but I think by the end of the year, that one will be sorted as well. Most useful comment that I get, that I've had from the various visits I've had from the different groups coming down, I think it was either from Derby or Nottingham, that costed out the amount of money that it cost to dictate the letter, to write the letter, and then to check the letter, and then upload it. And they worked this out to be about £4,000 a year, which essentially covered the cost of the registry. So patient experience. This is actually a thank you letter. The first quote is a thank you letter that we got. I'm just going to read this one out. I've always been so impressed with the IBD nurses. They always remember my colitis history. Now, I have some very good IBD nurses, but they can't remember the history of all 2,800 patients. So this is actually a thank you to the registry, I think. So I did do a quick audit of about 40 patients coming through in the clinic, and essentially I had no negative comments. None of the patients seemed to mind the time taken to put in data. And these are the sorts of quotes I got back. I don't mind the upload in clinic because I know the information will be available if I have to phone up with a flare. And then this lady, I like the new letter system. Last time I was able to notify my GP instantly of my medication changes. Now this lady, she literally walked out of my clinic and went straight to a GP, which is only two streets away. I reckon that the page was still hot out of my printer. So this one, simple comments here. It's the way forward. it's all going electronic anyway, and I think that's a reflection of our trust as well. So I'm going to leave it there because this has partly been covered already. It's just about the consenting, only to say I've not had any problems with any of the patients consenting for the full range of aspects here. The only issue I've had is with one, and he said that he was wary about his personal data, wary about the term pseudo-anonymized. In the end, he consented for locally held data, but not for the registry, not for research, and not for our own in-house project through Patients Knows Best. Thank you.